Right, good morning everybody and welcome to this meeting in public of the Board of NHS England. Particular warm welcome to those who have joined us in the room here in London this morning and to the multitudes who are watching the live stream across the world. It's a very important aspect of the way in which we do business, which is that we simply believe that the population of England deserve to see how decisions are taken which fundamentally affect the way in which the NHS provides its services to the population. So a very warm welcome to everybody. A couple of housekeeping issues. First, to say that there is no fire alarm scheduled for the course of the next 2 or 3 hours. We just had it. So if the alarm goes off, that will be for real, and our staff will escort people off the premises into a place of safety. Secondly, to report apologies for absence this morning. I have apologies from Wendy Becker, from Richard Douglas, who's our new Associate Non-Executive Director, being also a Non-Executive Director of NHS Improvement. And on this morning's agenda, we will be considering the development of our future closer and closer working relationship with NHS Improvement. And then thirdly, from Noel Gordon, who is also unable to join us this morning. So we have, of course, these meetings that we have in public, but as a board, we also spend quite a lot of time working around strategic issues, so that some of the business that comes to the board meeting today and at our meetings more generally has been quite heavily digested and preceded by vigorous debate around the board table in a strategic session. And for example, yesterday the board spent some time thinking about prevention as a critical strategic issue with which we need to engage and embrace, and which will come back ultimately as a formal paper to the board. So the board operates also through committees, and we will have today the written reports of the various committees coming to the board. So on that note, let me formally open the meeting. I'm going to invite the board, as I must always, to let me know whether there are any declarations of interest or potential conflicts of interest with any of the matters on the agenda, over and above the declarations that we hold on file from every board member. No, nothing's come up. And by the way, could I just remind board members, you'll have in front of you your personal register of interest. If anything has changed since the last meeting, please could you ensure that that gets amended. So we're now going to, so let me just say also, we've got 3 additional attendees. Bruce Warner, who's the Deputy Pharmaceutical Officer, will be joining us for the paper on over-the-counter medicines. I'm delighted to welcome Professor John Newton from Public Health England, who will join us for the discussion on health inequalities. And Neil Churchill, of course, of our own team, will join us also for that paper. So I'm going to turn now to the minutes of the previous meeting. They've been circulated. Can I invite the board to approve them as a fair and accurate record? Thank you. I've not had notice of any matters arising from the minutes, and I have no matters arising because we've got quite a lot on the agenda, which are continuation of previous business. But yes, please, Steve.
I think at the bottom of the membership list, it lists my predecessor rather than myself, so I've asked for rather than Bruce.
Oh, well, apologies. Apologies.
You're still the new Bruce then, Steve.
Yeah, I'm still. No. It takes us some time to adapt to the new regime and the medical directorate.
Taste, I'm sure.
But thank you so much for pointing it out, and that's a very important amendment to the minutes. Do I have your consent to have that amendment made? Okay, thanks very much. Apologies, Steve. Okay, so let's move on then to the Chairman's report, which can be agreeably brief because, as the board is aware, I've taken a period of leave during the period between the last meeting and this one. And I would simply like to do 2 things. First, to express my gratitude to David Roberts for stepping up formally as acting chairman during that period. And then secondly, to observe that whilst physically absent, I have actually been engaged to some extent in continuing discussions with Dido Harding and our relationship with NHS Improvement. And that secondly, I want to report publicly on the Everyone Counts Awards that the board conferred yesterday on 8 of the staff of NHS England to respect and to congratulate them on the nomination by their peers for the work that they had done going the further mile and being an inspiration to their colleagues. So we had 8 individual awards and then 1 team award, respecting the fact that so much that is done effectively across the NHS is done not by individuals acting atomistically, but by teams working collaboratively and collectively. And I would like to put formally on record today the board's appreciation of the work that is done and which is reflected in the awards ceremonies that we hold every 6 months or so. So nothing further to report in the Chairman's report. I'm happy to invite any questions or comments on that, but since I see no reactions around the table, I will move on to the report from the Chief Executive. Simon, over to you.
Thank you, Malcolm. So since we met on February 8th, as usual, I've been out and about doing various things, visiting a health service in East Kent on a Sunday, visiting local government services, voluntary sector services and NHS services in Plymouth. Last week I've given evidence at 4 parliamentary committees. I have spoken to the Diabetes UK annual conference about the shared work programme we have on improving care for people with type 1 diabetes and obesity reduction. I have spoken at the Freedom to Speak Up Guardians annual conference and confirmed what NHS England had previously committed to, namely that we would grow our number of Freedom to Speak Up Guardians from 1 to now 37, and that at least a third of those would be staff drawn from BACA minority ethnic backgrounds. I had the opportunity to speak to the Ambulance Leadership Forum, and they're committed that we would support the ambulance service in a piece of work over the next 6 months, giving frontline ambulance staff, paramedics, technicians and others the opportunity to work with us on what they see as the changes that are needed in the ambulance service and the way the emergency care pathways have worked over the course of this winter. Also observing that the recent results of the NHS staff survey show that ambulance personnel are, I think around a third of ambulance personnel report being physically and violently assaulted by members of the public over the course of the previous year, which is obviously completely unacceptable, and therefore we want to work with the ambulance service and with prosecuting authorities to ensure that prosecutions are brought whenever they can be, and we'll be funding a monitoring exercise with ambulance trusts to track the extent to which that happens. I also had the opportunity to speak at Jane's Nursing Leadership Conference, as well as the NHS Improvement Provider Chief Executives event and the Nuffield Health Summit. Since we also met on February 8th, the Department of Health and Social Care, with ourselves and other partners, have released a further 760 million of capital investment approvals for mental health, community, A&E, GP and hospital schemes across the country, have reached an in-principle agreement with unions covering more than 1 million staff for the Agenda for Change pay deal, and set out the location of the expansions in medical school places and the establishment of 3 new medical schools across England. So it has not been a quiet period. Obviously, all of that has been overlaid on the continuing pressures that we will hear about from Matthew over the winter period. And as we approach year end, I think we again put on record our thanks to the staff of the NHS who have done a really amazing job under very constrained and difficult circumstances over the winter period. We will obviously be reviewing our own full-year position subsequent to the end of the financial year, but I can assure the board that we will have met our statutory duties, including our statutory financial duties for the year which is about to close. It's also therefore the case that at this point our focus shifts to the year ahead, and in particular to the operating plan that the NHS needs to put in place, as discussed at our November 30th meeting and our February meeting, and Paul and Matthew again will update on that. We have an agreed mandate and remit letter for NHS improvement. There's still quite a lot of work to be done around the CCGs and trusts in terms of activity plans and capacity planning for the year to ensure that 18-19 works. And underlying all of that, a year to the day from today, obviously the United Kingdom is set to leave the European Union, and therefore we have an intensified work programme with the Department of Health and Social Care and others to ensure that the NHS is ready for that. We will be talking later on in the agenda about the good progress that's being made on the joint working between ourselves and NHS improvements, so I won't cover that here. But in some ways, the most significant thing which has happened since our last meeting is the announcement, the agreement by the Prime Minister that the government will support the NHS to develop a long-term plan for the next 5 and 10 years. And the Prime Minister has written to me this morning with the timetable and the processes that we will jointly use on that, asking NHS England to work to develop the priorities and the goals that that plan needs to cover, working very closely, of course, with the Department of Health and Social Care, other NHS bodies, local government, and other public bodies. We're going to therefore have an intensive period of work and engagement during April, May and June. The idea is to agree the priorities and goals by the summer. That's the timetable the Prime Minister has set out in her letter to me this morning. So I think this is a very encouraging development, and one that I therefore, on behalf of NHS England, welcomed as timely and constructive. Thank you.
Thank you, Simon. Questions, comments to the Chief Executive? No, and many of those issues that you've raised, of course, will come up again in the course of our discussions on agenda items this morning. Thank you very much. Shall we then move on to item 4 on the agenda, Ian, which is the NHS England mandate and NHS improvement remit letter for the coming year.
So just a few brief comments from me. Inviting the board to note the publication of the mandate and the remit letter. It's primarily a roll forward of the goals set out in the 17-18 mandate. It reflects the jointly agreed planning guidance for 18-19, and I think it's very welcome to see the timely publication of the remit letter to NHSI this year, at the same time as the mandate, which is, I think, an improvement on the position last year.
It's a big step forward, and I think the ability to draw the mandate and the remit letter together across common ground provides a valuable foundation for us in the work that we're about to embark upon and bringing the organisations operationally much closer together. So any questions, comments on mandate and remit letter? No, I mean, we've seen it, we've observed it come through a lengthy process of engagement, and pleased to have it, and it sets for us the, as it were, the orders for the coming year of what we're expected to do against the resource that's made available to us. And being able to do that much more closely with NHS improvement will be, I hope, beneficial to the service as a whole. Okay, so we note the publication of the mandate and the remit letter. Item 5 is the Funding and Resource 2018-19 supporting the Next Steps document. Paul.
Thank you. The board will recall that we're required to publish our business plan each year before the start of the year, so this is a timely attempt to do precisely that. The objectives for NHS England and indeed for the NHS as a whole are of course contained in the Next Steps document, and so we concluded, if you remember last year, that it would be inappropriate to publish a kind of rival document setting out the content of what we'd be prioritising over the 2-year planning period starting last April. But we did supplement the Next Steps document with a specific technical annex, which is essentially what we're updating today, which contains information on how we're approaching those objectives in terms of our key duties and the resources that we're deploying both across the NHS and to carry out our specific organisational role in the delivery of the next steps. So as I say, what you have in front of you is the final draft of that technical annex. It contains no major changes from last year's document, and the allocations to the system, which are contained on page 10 of it, reflect the decisions that we took at our last meeting, again without variation. The document reconfirms the 2-year allocations we made last year for programme and transformation budgets. We didn't, though, at that time publish both years of running costs for this organisation, partly in anticipation of the reshaping of our organisation which took place last summer. So this document records for the first time the running cost allocations for 18-19, which, as you'll see on page 10, represents another year where we're required to absorb inflationary and other pressures to live within a flat cash settlement. The document, as I say, is largely technical in character. We have rather more interesting items on offer elsewhere on the agenda, so I wasn't going to dwell on the content of the paper before commending it to you for your approval. One specific, Malcolm, we are continuing to make minor adjustments to all of these budgets to reflect emerging pressures and opportunities. So as well as endorsing the document itself, it would be very helpful if the board could authorise Simon and myself to complete that process so that detailed operating budgets can be issued to teams across the organisation over the next few weeks.
Thank you very much, Paul. So this is a continuity item with some technical amendments. Can I invite any questions to Paul or comments on the document? No, I think it's in accord with what we've already approved, and this is a roll forward on some technical issues. So I invite the board to approve the document, but then pick up Paul's second request to us, which is that we delegate to Paul and to the Chief Executive any further updates that may be necessary before the final NHS England budgets are communicated for 18-19. Okay, we're content. So we've approved the document for publication subject to that.
Thank you.
Good. Excellent progress. May I then move on, please, to item 6 on the agenda, which is the paper on the draft contract for accountable care organisations, which seeks to update the board on the development of our approach to this.
Thank you, Chair. So most of the service integration happening in the NHS now is occurring through collaborative approaches with groups of providers and commissioners working more closely together. But it's also worth noting that services tend to be bought in bundles that don't always clearly relate to each other, with different terms and conditions, instructions, funding and incentive arrangements. GP services in particular are often commissioned through one set of contracts with community, mental health, social care or hospital-based services through others. And a number of commissioners have been clear that they wish to recommission services through a single contract to build in integration and remove some of those barriers. However, there hasn't hitherto been an integrated services contract designed specifically for that purpose. And so we've developed a prototype contract with input from some local systems. NHS England engaged on it in December 2016 and republished in August 2017. The contract largely reflects the generic NHS standard contract, but it would allow commissioners to bring GP services and other services together by incorporating provisions to allow the contract to be used to commission primary medical services as part of a broader package, to use one consistent set of terms and create an aligned budget across all services, as well as set targets for longer-term improvements in outcomes across the whole population rather than a particular part of it. NHS England is committed to a full public consultation on the draft ACO contract, and the contract will not be used prior to the completion of that consultation process. This paper merely attaches a short note of some of the most frequently asked questions and answers, given the wider public interest in this. And I'm asking that the board agrees that it should return to this matter for substantive discussion when we look to launch the consultation itself.
So this is an early flagging to the board of a matter that will come back to the board for further discussion and then for approval to launch the consultation.
Exactly so, Chair.
Okay, thank you. Let me open it up for discussion. Moira.
Very helpful paper. I just wanted to clarify in section 15, the population. I assume the population would not include, say, for example, a prison or armed services in the population for an ACO.
That is how the contract, I think, is currently constructed in draft. Yeah.
Thank you.
We have been working with partners, including the local government association, to try and make sure it can go beyond just healthcare, including picking up some local authority services.
Okay, but just to clarify, those folks continue to get free NHS services under the current arrangements. So where NHS England is the direct commissioner for prison health, we would continue to be so. So nothing about this in any way changes or weakens the free, high-quality healthcare that folks are getting in the way that you describe.
Malcolm, if I may.
David.
I think, Ian, one of the questions here is to what extent this contract, let's go forward post-consultation, assuming that through the consultation a draft contract of some form does emerge. To what extent does that become a mandatory contract for use by all relevant NHS bodies, or to what extent is it a voluntary opportunity for people to use it?
Entirely the second of those. It would certainly not be mandatory.
Okay.
And the reason for that is that a lot of local systems are finding they can make progress on integration without having to do the contractual and organisational rewiring. So this is merely an additional option,
That's what
potentially subject to the consultation.
That's what I hoped.
I think brings me to the question I was about to ask, which is how radical or otherwise is this, as opposed to, I mean, what we're trying to do is defragment the system and make it easier for people to work together. A lot of areas already are working together on a voluntary basis, pooling resource, etc. How does the draft ACO contract advance or assist or underpin work which is already going on?
So perhaps it would be helpful if I referred to a line I think that Paul Malbach, who is the Chief Officer of Dudley CCG, used when he gave evidence recently at the Health and Social Care Select Committee. I mean, his take was that in Dudley specifically, he said, I do not think we would be able to achieve as much progress as quickly as we'd like because we wouldn't have the singular drive of one organisation with everyone working to one set of objectives. That's the experience that he is finding in Dudley, but there will be different experiences in different parts of the country on this chat.
Okay, that's reassuring. I mean, we frequently find ourselves having to find ways of basing ourselves on the existing statutory arrangements, yet finding ways of overcoming some of the unfortunate siloisation that they give us across the provision of healthcare services. Okay, so let me invite any other questions or comments on this. Just bearing in mind that this is the FAQs which are being brought to us to advise the board, and we've got a substantive discussion still to come. Are we content to note the paper? Good. Thank you very much. So we turn now to the next item, which is the proposals to increase joint working between NHS England and NHS Improvement. Simon, do you wish to introduce, or shall I invite Emily?
Well, very briefly, and then Emily will. So this is obviously been in gestation for some time. We are clear that the legislation requires there to be separate bodies called NHS England and with distinctive functions that are distinguishable from those of Monitor and hence NHS Improvement. But nevertheless, a lot of what we're doing together actually could be done in a more integrated way. And so we've been working hard with the leadership of NHS Improvement to develop proposals for that. And frankly, I think, seen from the point of view of the rest of the NHS, it's the national leadership bodies of the NHS practicing what we preach. So to the extent that people are working in a more integrated way locally, it will help reinforce that if we can do the same nationally. And I think the kind of very practical way of thinking about what this means, as I discussed when we briefed staff earlier in the week, if you look at the brilliant BBC hospital series, the first of which was broadcast earlier this week from Queen's Medical Centre in Nottingham, that told the story of two patients. One, a 12-year-old boy who was waiting for spinal surgery, and relied on the brilliance of a hospital team. And in a sense, nothing we're talking about today is going to detract from the fact that individual providers of service are providing brilliant care with the particular responsibilities of NHS improvement to support that continue intact. But the second story was the story of an older lady with dementia who was stuck in hospital, describes the dialogue with her family about finding a care home and all of the frustration that meant for that woman and her family, and also, frankly, for the team in the hospital, the health and community health services and social care interactions. And that second set of things that need to get right for that lady are only going to be enhanced if we can make care integration work. And that's obviously happening locally across the NHS in the way we've just discussed, but we, the national bodies, have got to act as a force multiplier for and accelerate those sets of changes. So we're trying to do both. We're trying to do the right thing for that 12-year-old lad called Kieran, and we're trying to do the right thing for the woman called Mavis, and we've got to therefore take these two approaches in parallel, and that's what we're trying to do through these sets of changes. Emily.
Thank you. So in the paper, we're both asking the board to note some specific recommendations that we want to continue with over the next couple of months, and also to approve the general direction of travel of our joint working with NHS improvement. And it starts off by setting out the logic as Simon laid out, in that we have evidence that joint working at the point of service delivery results in improved care as well as delivery for patients. And the implication, and indeed the request from those running those services, is that we do the same at the level of NHS improvement and NHS England in terms of aligning the guidance and support that we provide to the rest of the NHS. So specifically, in terms of what we're proposing to go ahead with, is laid out starting at paragraph 13 of the paper. So we're proposing to establish integrated regional teams that carry out the functions of both NHS England and NHS improvement in each regional area. And each of those integrated regional teams would be led by a single regional director. Those in bringing the functions of NHS improvement and NHS England together, we believe that we need to separate out some of the current regions in order to provide those regional directors with an area that it's possible for them and their teams to cover to execute the functions of both NHS England and NHS improvement with respect to those areas. That would give us 7 regions across England, and the details of that are laid out in paragraph 15. The precise geographic coverage of each regional team is being worked through, so obviously subject to approval, we will detail that out with the current regional teams to make sure those areas make sense in terms of operational responsibility, and making sure that that works best for the populations that those regions are serving. We are also proposing to make changes to how we work at a national level, for both the national programmes that we run and the corporate functions which manage both organisations. Those remain to be detailed out, so we are asking again for the approval of our direction of travel as opposed to specific recommendations. And we will bring the details of those back to the board meeting where both boards will be present in May, to make sure that we continue to get your input and approval. Over the next sort of 6-8 weeks before that joint board meeting, the meeting where both boards are in the same room, we need to both do that detailed organisation design and development work to look at what these roles would be, but also what we need to change around the roles in order to make that work, because we know that just changing structure is not actually going to change the way that the organisations are able to work. So we will be looking at the leadership model, the capabilities of both organisations, the culture of both organisations, our governance and other organisational processes, to make sure we're creating something that will really work in practice. And in doing that, we want to work directly with the people who are currently carrying out those activities to make sure anything we recommend has been thoroughly tested. And we will also be working with our trades unions to make sure they're able to provide us the right input on how these decisions will affect staff. And in doing so, we'll be using our existing organisational policies and procedures around organisational change to make sure we can support staff through what will be for some people an uncertain period, as well as something that actually all staff have given us the feedback that they think is exactly the right direction of travel. So that's what we're asking for your input on today.
Thank you very much, Emily. I think you are aware and everyone's aware of the sheer commitment of this board to taking this forward. I think we all get, as do our staff, that conceptually, philosophically, it's clear, it's simple, it's straightforward, and we should be doing it. But we also understand that operationally it's quite complex. We need to be able to respect the different statutory responsibilities of the two boards, but at the same time work from the principle of what is actually common, what we can do together, and how better we give a single message and a single regime in our interactions with those who provide healthcare services through the NHS. So I think it's a huge step forward, and one which I know the board is, having had an earlier discussion of it at our last meeting and the reports from Simon and myself, I know the board are wholly committed to this. So let's try to to look at some of the detailed issues, and let me invite the board to put some comments and queries to Emily and to Simon and others.
While those thoughts are forming, can I just make one other point, which I should have made at the start, which is that one of the things we want to do through this process is also raise our game on some of the areas where NHS England and the national leadership bodies of the NHS aren't where we want to be. So today, for the first time, we are publishing the baseline of the performance of the 6 national leadership bodies in the NHS on the workforce race equality standard. That's for NHS England, Care Quality Commission, Public Health England, NHS Improvement, NHS Digital and Health Education England. And I think that shows that whereas some progress has been made in just the same way as the NHS as a whole has got a lot of work to do in this area, so too do the national leadership bodies in the NHS. And we need to hold ourselves accountable for progress on that and use the NHS England and NHS Improvement joint work programme to ensure that that advances this rather than puts it on hold or moves it backwards.
No. I was just going to say, Malcolm, that agree that it's great to see such progress. I think it's good, given that, in a sense, that's what we're asking the system out there to do, is work across these fragmented organisations and come together in the interests of patients. It's good that we're doing it ourselves, and hopefully as well we will be learning from some of the changes we are making to support the joining up that's going on in the system as a whole.
Joanne.
Emily, thank you for that. I think it is, as Malcolm said, a really important step forward. Of course, we know that when organisations go through a lot of internal change, they can tend to get a bit inward-looking. So we're obviously going to have to guard against that. Yeah. I wondered if you might be able to tell us a bit about how you think the greater integration of our teams at a regional and local level will affect NHS bodies, which at the moment are dealing with both us and NHS Improvement as separate entities. So what will the changes mean to them?
Shall I respond specifically to that one? I think I can bring in a point from the point Murray was making as well. So when, as I'm sure everybody on the board has done, we talk with those who are delivering healthcare, so provider chief executives. I had some conversations with STP leaders, for example, GP organisations and individuals. When I asked them the question, what can we do to be better at supporting you, the answer is line up what you're doing with what NHS Improvement is saying to us. And I'm sure NHS Improvement colleagues are getting the same feedback, that it's very challenging to juggle competing demands, or even, frankly, not competing, but parallel requests for the same pieces of information. So one leader told me about an example where they'd been called at 8 o'clock by somebody from NHS England about whether they cleared the snow from the car park, and then they were called at 8:30 by NHS Improvement to ask whether they cleared the snow from the car park, and they would rather be clearing the snow from the car park than reporting to both of us. So that goes back to the point I referenced, which is we have to change what we're doing as well as change the roles that are doing it. So just changing the structures won't actually necessarily address that snow clearing inquiry. We need to actually look at the information flows about how we collectively and how these joint roles interact with the system, how we share information and how we have a joint version of the truth. And indeed, when we discussed these proposals with the NHS Improvement Board last week, that was one of the issues that they raised, is how are you going to get to one version of the truth? And I think that's absolutely our intention, and Paul and Elizabeth from NHS Improvement have been starting some of those discussions, but it's going to take work to do that. We need to keep doing that, basically, to make sure we can simplify in line with our legislative responsibilities how we share information and how we work with the system collectively.
Thank you.
Michelle.
Thank you, Emily. Could you briefly explain how this will result in benefits for citizens and patients?
I mean, I think Matthew may want to also comment on this, having had some of the same conversations. Obviously, the goal is to provide clearer, more integrated and simpler leadership and direction into the system, and to facilitate the cross-working that's required in order to deliver care to patients like Mavis, who Simon referenced earlier. And it was obvious from the interactions that were shown in the programme that there were challenges in speaking to multiple different entities to try and get clearance for her to leave hospital. And we're hoping both by demonstrating that joint working, but also by practically providing that clearer guidance into the system and a more aligned view of what we think the system should be doing and how they should be doing it. That will simplify the processes in terms of delivering patient care. It will take less time for people to be managing into two separate governance and assurance processes, much as some of those will still need to be separate, right? And we're not proposing to change that. So we're hoping that frees up time at the front and in terms of how healthcare organisations are provided, and make sure we're focusing in the right way. And it's also in terms of some of the less direct effects. So we've talked about how we both talk about quality, which Steve and Jane will talk about later, and how we work more clearly together to provide that guidance into the system, how we deal with inequalities and how we provide leadership to the system on that as well. So it's perhaps indirect in some places, more direct in other places, but overall it's about making sure we are focused, and therefore the system is also focused on what's most important for the public more generally, but also patients specifically.
Thank you.
Matthew.
Yes, thank you, Malcolm. I think Emily's captured that well. All I would add is that I think we need to see this tightly in the context of the STP ICSs that we're doing here. Chris Ham from the King's Fund talked about those as being the NHS's first ever bottom-up reorganisation. And I think that concept that we're trying to construct from the individual patient and from the places that they live, how should the NHS run, and the way in which that's brought together institutions locally across health and social care to start to rethink how you deliver health services there. This is a set of changes which is a response to the needs of making that successful, that it was becoming a blockage, that we were sending two messages down into the system that we were asking to work as one. And so I think if all the time we keep remembering that this is actually about empowering the ability of the local NHS to deliver services for individuals and for communities, and therefore what do we need to do, rather than this being a top-down, we've decided to reshuffle the national organisations, we have a fighting chance of making things better at the end of it. So I think that tie through to what is it we're trying to achieve is critical to when we're thinking about, so what do the committees look like nationally?
I think that's a very, very valid point indeed. The complexity of getting two different organisations with different cultures and different structures to work together closely can go back to the point that was made, I think, by Joanne, compel us to be much too internal looking as opposed to understanding what is the end game that we're after. But I think the interesting thing is that this is actually the NHS itself, within the framework of the legislation, restructuring how it works in order to demonstrate how better we can deliver services to patients. I've got Steve and then David. Steve?
Thank you, Malcolm. So Simon mentioned earlier the staff briefing that he undertook on Tuesday jointly with the Chief Executive of NHS Improvement. And in fact, a similar briefing was held for the staff of NHS Improvement. I was privileged enough to be with our staff in Leeds on Tuesday to watch the joint briefing and then to host a question and answer session afterwards. And I was struck by the overwhelming sense of support I got from the staff that this was absolutely the right thing to do. And I know other executive directors were undertaking similar question and answer sessions at our various sites, and I think that is also the sense that my fellow executives got from staff. I think, however, we should acknowledge that change is always challenging, and this will clearly be a time of change for staff. The other sense I got was that staff were really appreciative that we'd involved in an early briefing, but also a desire to help us to co-design the future. And of course, like any organisation, we are our staff, and I think it's really important that they come with us on this journey.
Thank you. David?
So, Malcolm, three observations, stroke thoughts, Emily. I think they're all... one is, these are two very, very different organisations. They've grown up with different heritage, with different leadership styles and approach, etc. And therefore, as much effort, I would suggest, needs to be focused on the integration, the creation of a new culture, and the integration of teams as it is on the structure and the appointment process. And my experience is that's the bit that gets left, because it's the hard bit, actually. And therefore, I'd be intrigued to know, maybe not now, but maybe at the next time we come to this, how we're thinking about that. What's the way in which we're going to do that? I think the second item, this is a very significant change on multiple levels that will impact a lot of the system that sits above the people who do brilliant jobs delivering care every day. And there's a real balance, I think, between the degree of change versus sort of the support for the system, and that just tells me speed is of the essence. And therefore, the regional team integration, which is the most important and the first, in lots of ways, can we go further in getting it done quickly, not just at the top level, but in the intermediate team members as well, because otherwise we run a risk of paralysis. I think the third thing is your clearing snow in the car park. We should be very alert to that risk at the board level, and we should, as we work from the bottom up, as Matthew said, we should make sure that Malcolm isn't asking for snow to be cleared on one day, and Dido expecting for snow to be cleared on another day. So how can we get, stretching that analogy somewhat.
I'll just point out, for once, it isn't actually snowing. Right? So that would be... Yeah.
So actually, we need, as alongside that, and for Malcolm really, and for Dido, we need to ensure we've got the right integration of governance, respecting absolutely the legal responsibilities that we have, with a view of making it simple for people so they don't spend all their time talking to us, and they spend a lot more valuable time leading their teams.
Thank you. I have Jane and then Moira.
So I just wanted to make the point that for the last 6 months I've had the privilege, opportunity to be the regional director for London as well as the CNO. And so when we discussed this paper, I can see it both from a national perspective and a regional perspective. And I think some of the lessons I've learned over the last 6 months is that people in the NHS, patients using the NHS, do not see it as multiple organisations. They see it as a national health service. So for them, they won't worry about who does what, as long as it gets done, and it gets done seamlessly and on time for them. And the staff I've spoken to and the providers, the commissioners, all say the same thing. Say it once, say it with the same voice. Let's have some clarity. Let's have some streamlining of the messages and the work. And although across London we have tried very hard to do things together, there is duplication, and I think the changes that we're proposing with NHSI will benefit both our staff and the outcomes that we're trying to achieve. So having lived and breathed it for the last 6 months at a regional level, I can really see the value in what we're doing and how we can move that forward. So I think it's the right thing to do, and I'm really grateful that we've got an opportunity to do it.
Thank you. Moira.
A narrow point, Malcolm, but I would welcome, in relation to paragraph 16, commitment that the boundaries will respect the boundaries of local government in any changes that are made.
Did I see you nodding at that, Emily?
I'm running through it in my head and
Risk.
thinking that's almost certainly the case, but we will make sure that's one of the checks that we do.
Yeah, I think it's one of the criteria that
Yeah.
certainly needs to be addressed if we're going to reduce the
Yeah.
complexity of non-territorial
interactions, yeah.
alignment. Yes. Okay. Great. Well, look, I think in summary we should be clear that there is, from the leadership of both of these organisations, the strongest possible commitment to doing this and to doing it at pace. I think secondly, the ideal outcome is that we have as far as possible a single organisation and a sense of a single organisation, knowing, however, that legally we cannot produce that as a legal entity. But the message that Jane just gave us is how the world sees this and how patients and the population see the NHS is the critical one. We have to overcome the institutional barriers so far as we can within law to providing a single seamless service. The bulk of our staff will be employed on a single basis through the regional offices, and I think sooner that we can get those established and up and running, the better. And then finally, we've got some quite complex bits of governance, and they're complex because of the pre-existing arrangements that we've got, but they're not irresolvable. So I think the accelerator principle applies here, that we can drive our way through all of this and give the assurance to our staff and to everybody else that this is the new regime, this is how it's going to look, this is where you will fit in, these will be your responsibilities and your remit. And also, these are the opportunities that are made available by this new structure, which presently frustrate us because of the barriers to cooperation that we've got. So may we just, Emily, commend you and the team for the rapid progress actually that's occurred since we last looked at this, and give you the strongest message that we would like to see the same pace in the run-up to the May meeting, when we will come together and take these proposals together. Are we okay with that? Great. Thank you very much. We're going to turn now to item 8, which is the over-the-counter medicines item. Greetings to Professor Bruce Warner. Bruce is the Deputy Chief Pharmaceutical Officer. He's sitting now alongside Steve Powers, who will introduce the paper.
Thank you, Malcolm. So the board will recall in its November meeting that it agreed to consult on draft national guidance for CCGs, which sets out proposals to restrict the routine prescribing of over-the-counter or OTC products for 33 minor and or self-limiting conditions. The consultation also proposed to restrict the routine commissioning of vitamins, minerals and probiotics. Jointly with NHS clinical commissioners, NHS England consulted publicly on these proposals between the 20th of December 2017 and the 14th of March 2018. And we agreed to bring the findings back to this meeting for board members to consider and to agree the next steps. We received a total of 2,638 online responses to the consultation, 65 responses by post or email, and a further 122 responses to the easy read version of the consultation. And in addition, we held a series of webinars for stakeholders and face-to-face public and patient events. We also held individual meetings and held targeted focus groups with key stakeholder groups, including older people, individuals with learning disabilities, and citizens' advice clients. Of the total number of respondents, 57% were either patients or members of the public, 33 patients, 24% members of the public, and a further 17% of respondents were clinicians. Overall, there was broad support for the proposals, with over 60% of respondents agreeing that we should no longer routinely prescribe OTC products for the minor conditions identified in the draft guidance. For each condition consulted upon, at least 58% of respondents were in support of no longer routinely prescribing the OTC products used to treat them. Most aspects of the final guidance which board members are considering today remain unchanged from the draft on which we consulted. However, as a result of the consultation feedback and consideration by the clinical working group, which developed the guidance, some important refinements and clarifications have been made, and those are in the documents before you. So, with that context, would ask the board to carefully consider the report of the consultation findings and the final proposed guidance to CCGs, and ask that board members approve the final recommendations and also approve the publication and dissemination of final guidance to CCGs. And as you have pointed out, Bruce has joined me here to provide expert advice. Thank you.
Just to clarify, the next step from that would be for the CCGs themselves to adopt the guidance. That is right. This is not self-implementing.
Yes, correct.
Okay, that's helpful background. I mean, for the board's benefit, I think the comments that Steve has made set the context. We've already approved the principle of this. We've been out to consultation. We must, of course, then listen to the consultation, take into account what we've heard back from those who've responded to the invitation, and then think through the recommendations that we make on the basis of that. So the board paper provides us with the foundation for doing just that. So in that context, let me invite Jerry. Oh, I'm sorry, Michelle. Whichever.
Go ahead.
So polite. Could you just talk us through how the proposals have changed based on feedback, and in particular assurance about some of the most vulnerable people who may be affected?
Yes, so that was something that came up quite regularly in the different consultation events that we held, particularly around patients that potentially may be disadvantaged because of low income. But we felt, I think, within the clinical working group that they weren't necessarily the only group that needed to be considered. And so an exception was put in around social vulnerability, which we felt would cover a range of different social situations where patients where it was considered there was a potential they wouldn't access those medicines, potentially because of low income, but also because of other vulnerabilities within society. And so where that was considered to be the case, then this guidance wouldn't apply, and they would continue to get their medicines through their GP as they always have done.
And I would just add that that is in paragraph 27 of the document.
Thank you very much for doing this work. I think it's always hard to take away something that people have regarded as an entitlement, and it's not an easy thing to do. And it's interesting how much support there was for the proposals. I personally am sort of very reassured by the exceptions and the safeguards that are in the document. And I wanted to say that I think it's a positive step to enable and encourage people to look after their own health and the health of their families. And the onus is very much on us to provide support for people to do that with our information advice and our online resources. And I think, finally, that it's important for us to make clear in those resources that these over-the-counter products for minor and self-limiting conditions will not normally be prescribed by the GP, so that people know that and feel encouraged to go out and get these things sorted for themselves with the advice of pharmacists. So thank you.
Myra.
Could I ask that I think it's the fourth paragraph in section 1.5 of the actual guidance, that it says the guidance applies to all patients unless they fall under the exceptions outlined. This includes those who would be exempt from paying prescription charges. Do you think that's 100% clear to a reader of that?
We've tried to make it as clear as we possibly can. I think what we wanted to try and make sure was that there wasn't a perception that an exemption from prescription charge on its own exempted this guidance. We need to remember 90% of prescriptions that are dispensed in England are exempt. And so that on its own wasn't considered an exemption, unless any of the other exemptions
It takes
apply.
a little bit of working out that's what
It
that
did.
says.
You're making a textual point rather than a
Yeah.
Sorry, I am.
I would say there are a
absolutely
few minor amendments that
Right.
I have put forward
Okay.
to clarify those sorts of things.
am. Okay.
They didn't make it into the papers for the
Okay.
board, but will make it into the final issue
It
document.
does. And could I then just follow up and say, under the general exceptions to the guidance, just for clarity, that the last bullet point, individual patients where the clinician considers that their ability to self-manage is compromised, would that include the residents of care and nursing homes?
Not on its own, not by default anyway. So residents in care homes, nursing homes, they are in effect in their home. And of course, if any of the other exemptions applied, then they would apply to those as well. But simply being in a residential or care home on its own wouldn't be an exemption per se. So those homes do have policies called homely remedy policies, which allow over-the-counter medicines to be used with those residents, and of course they they have the same rights as anybody else living in their own home, but living in a home by itself wouldn't be considered an exemption to this guidance.
That's in both care and nursing homes?
Yes.
And there is obviously a concern that some of the cost burden is being shifted to the care sector rather than to the NHS. Can you assure me that that isn't the case, as it were?
Well, it's the burden would shift to the individual resident or their families or whoever is looking after them. So it wouldn't necessarily be to the care sector, but it would be treated in the same way.
At this point, a resident in a care home, it would shift to the care home, wouldn't it?
Well, it would shift potentially, yes. Although a lot of patients and residents in care homes will be buying a lot of these medicines anyway themselves.
Yes, but lots of them won't be.
Indeed.
That does raise the question, of course, to the extent to which GPs are already advising patients not to take a prescription but to go and purchase the items over the counter. And I can see this makes it quite difficult to assess what's the financial implication of what we're doing. It strikes one that the global overall potential benefit is quite diminished when we come down to what we're actually assessing after we've gone through the various exceptions and the listening to the consultation, which is absolutely right. Mm-hmm. But one wonders whether this takes into account, shall we say, the full transaction cost if it were to lead to fewer visits to GPs and more visits to pharmacists. Now, I'm quite taken when I look at the NHS Choices website, and I've looked at nappy rash and cradle cap and all these things just to...
as a grandfather.
Yes.
Not personally, Malcolm.
No. There's other areas in here which I wouldn't venture into, but I'm just fascinated that actually already the advice is don't go to your GP. Already the advice is, if necessary, consult a pharmacist, but the pharmacist in light of an OTC remedy. So are you happy that throughout there is now an alignment between what we're proposing here and what advice we've already put into the public domain?
Yes, I think we are, Chair. I think this aligns very well with the Stay Well This Winter campaign, with the Stay Well Pharmacy campaigns that have been launched earlier this year, all of which are trying to promote the self-care agenda and trying to sort of ease the burden on general practice and as I say, promote that sort of self-care agenda across the whole system.
Well, just to be clear, this doesn't remove the judgment of an individual GP to prescribe where they think it's necessary.
That's correct.
Just to be clear.
Yes.
Right. I think we're done. I think just to first of all invite the board formally. Can I just check with the board? We've got 5 papers. Much of the material is familiar to us, but this is a formal report to the board, including the report on consultation and the draft guidance to go out, that the board have got all of that paperwork and have absorbed it. So can I then ask formally the board to consider and note the findings of the public consultation, summarised for us here, both in the main paper and also in the summary paper, to approve the final recommendations, and to approve the publication and dissemination of the guidance. As we noted earlier, that then goes out to the CCGs and it's for them to do the formal implementation. Is the board content to approve all of those recommendations? It is. Good. Thank you very much, and thank you, Bruce, for joining us. So we turn now to a paper on current trends in health inequalities. It's a scene-setter paper, but I'm very pleased that Professor John Newton from Public Health England is joining us, and also Neil Churchill from our own inequalities team. So welcome and thank you for the work that you've done on this and for the assistance you've given us. I'm going to invite you, Steve, please, to kick us off.
Thank you once again, Malcolm. So the purpose of this paper is to brief the board on health inequalities in England. The paper sets out the current position regarding life expectancy and demonstrates the persistence of inequalities in health outcomes. It contains a number of examples of how NHS England is addressing health inequalities and opportunities for where we could do more. It sets out a number of next steps, but at a higher level, we would ask the board to do 3 things. Firstly, to recognise and acknowledge the persistence of health inequalities. Secondly, to agree that the reduction of health inequalities should be a key component of our strategic future health planning. And thirdly, to ensure that our current programmes are, wherever feasible, directed towards the reduction of inequalities. As you pointed out, we're joined today by Neil Churchill, who heads our health equalities team, who led the preparation of this paper on behalf of Jane, the chief nurse, and myself, and by Professor John Newton from Public Health England, who's an acknowledged expert in this area.
Thank you very much for the introduction. Jane, is there anything you wish to add?
No, nothing to add, thank you at this point.
Okay, well, let's kick off the discussion of the paper. It has some quite stark data in it.
There may be something that John and Neil
Yes.
might want to add at the start.
Please, John.
Yes, if I may, Chairman. So thank you very much. And we very much welcome the content of the paper and the attention that the board and NHS England is giving to health inequalities. And as you said, it's a great opportunity to incorporate that thinking and that strategy into the matters that Simon mentioned, the new opportunity to set long-term priorities, but also to almost all aspects of your business. For example, the new contracts or ACOs could have some mention of health inequalities. So that's all very important. And I think implicit in this is that whilst it is, of course, very important that health services do what they can through their normal business to address health inequalities, the evidence is that the majority of health inequalities, the cause of that lies outside the direct action of health services. So the question for the board is how the NHS and NHS England should support actions that occur outside the health service which are going to improve health inequalities. Because unless those actions take place out in civic society more generally, we will carry on seeing persisting health inequalities. That is what the evidence would suggest.
Because health inequalities match very closely social inequalities.
They do, yeah, indeed. And I think there is a lot of recent activity, so I think there is a huge opportunity for the NHS. So Public Health England has been working with local government, but also with many other sectors of society to address those causes in a place-based approach. And I think the input of the NHS would be extremely welcome in those settings, and there's a great deal that could be done. I very much welcome the mention of work around the Social Value Act, but I think there is more that could be done, and we'd love to work with you to develop those opportunities.
Well, thank you very much for that offer, and it's, of course, reciprocated. But let's open up the discussion of the paper. Who would like to kick off? I have Michelle and David.
So I think it's a really great scene setter, and obviously an issue that many of us feel very passionate about. On quite a practical level and pragmatic level, I'm really keen to hear just the next level of detail of the plan for particularly 18-19, 19-20, and how we can feed in to a more strategic reflection of this issue with the long-term planning process. So what change can happen next year and the year after?
So as I said, there are examples in the paper of things that we are doing now, which we believe will have an impact on health inequalities. So one area, for instance, is that over the course of the next year, we will be moving in terms of bowel cancer screening from an existing methodology, which uses a test for fecal occult blood testing, through to a better system, which uses a newer test. And there is already evidence that by doing that and by making it easier, that will allow improved access to bowel screening for members of the public who previously may not have accessed those services. And because early detection of cancer is one of the key ways that we can improve health outcomes in cancer, then by adopting that new approach, we would expect to see an impact over time, because these things do take over time, on health inequalities. As I think Malcolm discussed earlier, we spent some of the board development session yesterday talking about the prevention agenda, and I think we concluded from that discussion, as we move forward on that, that we should focus on areas of prevention, such as cardiovascular disease prevention, that will target health inequalities, and will focus those programs of work at areas, whether it's geographical or patient populations, where we would hope to see the biggest gain in inequalities. As I said at the start, this is an overview paper. You've pointed that out. I think the commitment would be to develop that list and to bring that back to the board or the relevant board committee in the next couple of months so that we have a very practical list. And that was why at the start I said the third thing I want the board to do is to agree that we should ensure that our existing programmes are focused. But I think there's also an opportunity, and Simon has mentioned at the start the process that we will be beginning to start around looking at the next 5 to 10 years. And the second of my points was to make sure that we make into that work a real focus on the reduction of health inequalities.
Thank you.
So, I guess as I stand back and look at this paper, I sort of feel encouraged and not encouraged, I think is how I'd sort of come at it. And I think what I see is a series of effectively initiative by initiative actions to tackle health inequalities, all of which are really, really important, all of which we need to I would also suggest redouble our efforts on, because the data is clear that the inequality is getting worse, not better. Now, you can argue till the cows come home about why and what are the drivers. And I think it's very clear that health is not an island outside of broader social things. But I am concerned about, well, not concerned, if I was in my sort of corporate world or my society world, so this would say the data's got worse, we need to understand more about why. We need to tackle the issue holistically, not only in initiative by initiative. What gets measured gets done. So where is our target? Who's accountable? What are our processes? And how do we set out a long-term vision as well as a series of initiatives? Which then links me, Steve, as you rightly said, to the sort of 5 to 10 year work. But also I think it's probably as important that we start to think about the strategy and our aggregate approach and where are the gaps and what's the measures and what's the accountability, as much as we do the critical work of improving the by initiative. So my challenge is more to Simon, really, which is about, from an organisational perspective, I think you're intending to come back on this, but I would like to encourage you to come back with the outlines of a strategy, but also with what's the nature of the ambition, what's the nature of the target, the accountability, and the key initiatives holistically, as well as initiative, walk, both in the short term, as Michelle rightly said, and also in the long term. Somebody very wise told me that you should walk and chew gum at the same time. I suspect it has to be sugar-free gum now. But actually we need to do both. We need to look to the medium term as well as do the short term, because this, quite frankly, is something that we need to work on and seek to make improvement in, because it's not a great story for the country in aggregate, not just the health system.
Exactly. So that's precisely why we put the paper here today, picking up on the conversation we had at our last meeting in February. And I think there are sort of 2 or 3 layers to the onion here. As Michelle says, there are the concrete things that during the course of the next 12 months, as we advance on the improvements in cancer services, mental health services, the strengthening of primary care networks, the design of integrated care, as John said, to kind of build in targeted prevention that will counteract inequalities in particular parts of the country. We need to be tangible in measuring that, and we do have data gaps in certain areas. The inequalities data in the usage of mental health services, for example, is still far too poor. We need to work with NHS Digital on that. So there's that layer of the onion. The second layer of the onion is the broader game plan for the NHS over the next 5 or 10 years that we're going to be developing over the coming months. And the third layer of the onion is the broader societal impacts on health and inequalities, where they're not within the control of the NHS, but where the NHS can certainly advocate for healthy public policy and other changes that will catalyse effort on the part of, be it private sector employers or local government or the voluntary sector, or on matters such as childhood obesity, the food industry and other participants. So those are 3 layers of the onion. We've got to work on all 3 of them at once.
So in the nicest possible way, when will we
we'll make May.
Hear about it next?
May will be our next public board meeting, and that's when we will come back for the first of those layers of the onion, the 18-19 programme. Sometime between the summer and the autumn will be the second layer of the onion, when we will set out the 5 or 10 year proposals in conjunction with our partners and government. And then the third layer of the onion will be to some extent shaped by PHE's broader leadership role. For example, the refresh of the childhood obesity strategy, the work that is going on in other of the wider determinants. But I defer to John on the third of those.
Good.
Absolutely.
Thank you,
Yes.
John.
Yes.
Yes, good. Jane.
Simon has probably covered pretty much everything I was going to say, but I think in terms of some of the perhaps more of the detail, more the granular, section 2 actually does talk about some of our responsibilities and how we can tackle health inequality. So we can do that in sort of 3 ways, building on what Simon said. But there is something about us working as one of the system leaders with our colleagues. So we've already heard about the importance of working with PHE, NHSI, others. And I think for us it's something about, it's referred to in the paper, but how we implement and deliver on the national 5-year forward view priority programmes. So they are all working on delivering improved outcomes for patients. They're all working on improving unwarranted variation, which is really important. But as well as doing that, I think we need to also specifically tackle where we've got a known obvious health inequality, where we've got data that shows that. And just actually being really specific about, so in delivering the improvement in variation, in delivering our priority programmes, how are we going to look at it through the lens of health inequalities, and how can we take some specific targeted action to be able to improve that and then measure that we've done it. And part of the way we can do that is through the commissioning function that we've got, but also we can do it through some of the work around integrated care systems, through our SDPs, through the devolution agreements we've got in various parts of the country. There are plenty of opportunities for us to do that, and I think by May we should be able to come back with some very specific actions that we can take for 18-19.
I think that's reassuring. I mean, health inequalities are baked in already to those national programmes.
They are.
The question is it sufficient, and
Exactly.
do we need to review those,
Exactly.
and how do we redouble our efforts?
Exactly.
Let me call on John and then Joanne.
Thanks, Malcolm. Since Newcastle's mentioned specifically as an example in the document, I can use that as an excuse to make a comment. Really a comment more than a question, and just to reinforce that this is a long-term challenge. As everyone on the board knows, I chair Newcastle Hospitals as well as being a member of Newcastle University and having lived in Newcastle all my adult life, so I'm more than a little interested in Newcastle. First of all, there's a lot of low-hanging fruit in terms of care of the elderly, and clearly looking at our funding allocations, we can make a big difference. Now at Campus for Ageing and Vitality is bringing together our council and our university and our hospitals to really address what can be done to improve the health of the frail elderly in particular. But it's also worth remembering that you quote that 3 out of 10 children in Newcastle live in a house or home with low income. And that reminded me just to remind us all of the 1,000 family study set up by Sir James Spence in 1947, when 1,000 families were given, or red spot babies as they were known, were flagged. And we're still following those 1,000 families, or the 1,000 people who have still survived 70 years later. And it's perhaps just worth reminding ourselves that the frail elderly, we're looking at the consequences of 7 decades of lifespan, and that it might sound that 3 out of 10 being poor now is surprising, but if you look at the results of that original study, the absolute desperate, abject poverty of many of those individuals when they were children is still being played out in their healthcare now. So when we look at the sort of short-term gains, and there are some to be had, we shouldn't lose sight of the fact that many of these health inequalities were built in throughout an entire lifetime. And even more so, from a geneticist point of view, in the epigenetic phenomena that if you starve a mother when she's pregnant, that will have an impact on the entire life course of that child. So some of this can't be fixed. And so what we have to think about is really putting extra resource into trying to repair some of this inequality. It's not simply a question of bringing them up to the same. We've got to do more to make up for that lifetime of deprivation in many cases.
I'll just add something at the end. But
I think that's a very good point, actually. There's a difference between equality and equity, and you're referring to equity. A couple of things. First of all, this is a paper that indicates a very welcome intentionality around this. My view is that this impacts on virtually everything that NHS England does.
virtually everything we've talked about on this agenda so far has an impact in this area. So there's a question for me about how we measure the impact of what we do on these groups. Let me give you an example. This has always been on my agenda, but I'm particularly concerned about cancer and the experiences of black and minority ethnic women in particular, and particularly those who are unlucky enough to receive a mastectomy, and the issues that they face in obtaining appropriate support. And it's very difficult to get at the data, to get at the information. And if we don't have the data, we don't have the information, we have no line of sight as to the experiences of those groups. And virtually every sentence that we make when we refer to our impact on populations is generic. So we take the view that a rising tide raises all ships. I think this paper indicates that some ships are laden with lead and they just don't raise. So there are a number of questions for me about how we approach the design of our programs. We don't build this in at the beginning, but we try and measure it at the end. So we could do something about that now, and we could do something about the data now. I guess when this report comes back to the board, I would want to see the specifics on that. And in relation to race, which is redolent throughout this paper, both in its presence and in its absence. In its presence, it's bad news, and in its absence, no news, which is frankly worrying for a public body. I would want to see that we were focused on the area in particular, not just cancer and mental health, but across the piece. I mean, even when we refer to A&E admissions, who do we mean? Is that a generic statement, or do we mean specific? And in some areas, it is about specific populations. So I do welcome the intention. I'd like to see the process behind it meeting that intention. I'd like to see the specifics and timetable when we're going to get the data, and I would like a much more, I'm trying to find the right word here, strategic and generic response in the way we think about strategy going forward and the way we report on it. Because at the moment, we can't say that we are providing a service which actually closes the gap on inequality, and we certainly can't say that we're doing that in relation to BME groups with confidence.
Yes, is this on the same thing? Bring you in before I invite John to...
Yeah, I think it's sort of similar. Inequalities often result from a universal offer being differentially taken up in a reduced form by so-called disadvantaged or hard-to-reach groups, so where access or uptake is lower. So it seems to me that one of the things in practical terms that we ought to be much better at is using what are more commonplace commercial or consumer techniques to really understand whether the universal offer is inappropriate or not helpful or doesn't meet the needs of specific disadvantaged populations. And then to use incentives, both incentives for provider organisations of various sorts to reach those groups and incentives for individuals to come forward and access services. So I think it's partly about modernising our approach to addressing inequalities. And I think if we can do some of that and the other things that people have been talking about today, we ought to see over the medium term some impact on our rather poor international standing on outcomes, which would be fantastic.
Can I just support that very quickly, Malcolm, because there are things missing from this that may support Joanne's point. One is the digital issue, which I think is something I'd want to see represented in any further discussion of this topic, because it is absent from this paper. And the other one is actually about our approach to sort of segmentation, which we don't, is missing. And I think the other thing that's glaringly obvious and missing is children. I mean, I don't think, I know it's not flagged up in any champion in the 5-year forward view, it's mentioned, but it's glaringly just not there. And we do have we are going to have to say something about it. It's kind of the elephant in the room, perhaps.
John.
I mean, it's really good points to make. I'll limit myself to a few. The important point not to conflate different aspects of inequalities. So we've got social inequalities, very important. We've got the inequalities of people with various protected characteristics, including ethnicity. We've got the problems of inclusion health. So particular communities like prisoners or migrants or homeless people who are, again, have another scale of inequalities. And those different types of inequalities require different types of responses. And then on the data, we are rather stuck in the old-fashioned approach of the Black Report of looking at variation in mortality rates. And we know from the global burden of disease, we've moved to a situation where the majority of burden is due to morbidity, and we have much less good data on mental health, on musculoskeletal condition, and all the drivers of demand for care. We need to move on in our data collection.
That's a resource issue, and we can make decisions about that.
I think it's a combination of resource and leadership and
I'll rest my case.
And determination. Yeah.
On homelessness, sorry, it's just worth pointing out that we need on homelessness and primary care, which again needs to be strengthened when we look at this again. There are issues around decisions that we're making that will impact on the provision of primary care to homeless people, and we're doing that because we're making decisions about allocation on primary care, but we're not considering its impact on that. Now, that's a fairly straightforward thing that we could be doing. It doesn't require particular... It's a leadership and attention issue.
Simon.
Yeah, I just wanted to underline some of the points that John just made very briefly. The first is that there is if we're thinking about the sustainability of the National Health Service, actually inequalities costs a lot. So researchers at the University of York estimated that there was a £4.8 billion cost to hospitals of socioeconomic inequalities from avoidable emergency admissions, about a fifth of the hospital budget in that year. Within the last 10 days, we have backed a report from the King's Fund and the National Housing Federation on the cost to the health service of inadequate housing, which is sized at about between 1.4 billion and a £2 billion cost. And that reminds us that as we celebrate 70 years of the National Health Service, Nye Bevan, of course, was not just Minister of Health, he was Minister of Housing and had a particular drive on high social housing development and standards, not least because at that time 2/3 of houses in the Rhondda Valley had no indoor toilet. So he insisted on space standards of provision as part of improving health of the nation. And we need to, we think about 7 decades, go back to some of that, picking up perhaps John's point as well.
Wonderful. I like the reference to the York University,
yes.
Because you know full well that is pinned to my wall, and I often quote it because it's absolutely about the money as much as it is about the moral case.
And I was 8 years old before I left the house with an inside toilet.
Right. Are there any other
questions?
And when did you learn to use it?
We were lucky.
Okay. Right. I think just to say, I think the paper is very welcome. Before we go on, I just need to say, Neil, you will have some of the responsibility of taking this forward. Is there anything else that you want to hear from the board?
No, I think that's very clear. I think the only thing I'd add in relation to the data point is also we have some areas where we have less data from patients themselves. So Victor mentioned the cancer survey, which is probably our best data set from patients. We have 66% of people with a diagnosis of cancer who fill that in. Contrast that with mental health, where we know very little about people's experiences of care. So I think there's some other elements of data that we might want to look at the balance of as well.
Can I just ask, sorry, on that point, do you, in order to do that, do you need the board to support a different decision about the resource that goes into getting that data? Because at the moment, it's all right you say it, but actually, if there's no
dialogue
resource
we
to
need
do
to
it,
have with NHS, actually,
right.
Noel represented on this board in spirit today, if not in person, I'm sure will be very supportive.
But is there anything that we need to do to shift resource in to make sure that happens?
I think it's a conversation as well with the CQC, who do run the community mental health survey on a relatively small sample basis, and I think it's probably a good time to look at collectively what do we do and have we got the balance right. And I do feel that probably for given the priority we're putting onto mental health services, we haven't put as much investment as we should have collectively into understanding people's experiences of them.
Okay, thanks. Well, very good paper. Thank you, John, for joining us, and Neil. I think secondly, the board is fully seized of this. It is actually one of our statutory duties, and we need to be fully seized of it. I think thirdly, we know already that whenever we undertake a new initiative or refresh an initiative, we take into account of health inequalities. But what I think we're hearing today is how do we measure the impact? How do we know that what we're doing is not only driving through generic policies, but also is segmented in accordance with where we know there are specific pockets of health inequalities. And that's inequality in terms of the state of health, inequality in terms of access to health services, etc., etc. So I think finally the context of the 5 to 10 year thinking about forward planning for the NHS and funding for the NHS gives us the opportunity to work, John, with you and the colleagues at PHE to ensure that we've got as good a grip on this as we possibly can. And within that, the context of that authoritative study from the University of York, declaring an interest, but which demonstrates effectively the economic impact of failing to grasp with this agenda. Good. Joanna, you're looking at... Right, okay, thank you. Good discussion, and one which we are, I think, determined to follow through. So we're going to turn from inequality to quality, knowing that there is also inequality within quality, but it is a different plane. So Jane and Steve, I think, are going to introduce the paper for us.
Yes, so thank you. This is another joint paper, so I feel embarrassed at introducing it once again. But having said that, a brief introduction. So high quality care is obviously at the heart of everything that we do. The 2012 Health and Social Care Act gives NHS England a duty to continually drive improvements in the quality of care across the comprehensive health service. So the purpose of this paper is therefore to brief the board on essentially to map out for the board NHS England's responsibilities and functions relating to quality. It also describes how we work on quality with other national organisations. So we would ask the board to note the functions, processes and governance in place across the organisation and how we work across NHS England in order to take action. And also to note our work with NHS Improvement in particular, but with other arm's length bodies to strengthen improvement capabilities across the NHS.
Thank you very much, Steve. Just to remind the board, this came out of a request from the board following our discussion of one or two instances of quite deep concern about quality complaints, the role of external review, and whether we had an effective and joined up process. And I think the paper goes some way towards not assuring us that we have an effective joined up process. So let me invite discussion around the board table. This is an unaccustomed period of silence. David.
It's an obvious place where bringing together the NHS Improvement and NHS England in better joint working, where I think material simplification and material simplification can take place. So I just encourage that to be part of the agenda.
Completely agree.
Moira?
Just to add, yes, I mean, I think, again, clarity about the roles of the national bodies and supporting the complexity, just this list and making sense of it all, and that's amplified if you're a local body, as it were, because there are lots of things that won't be captured at national level, and trying to make sense of it. So the kind of distilling and making, helping the sector to work effectively, rather than passing on, do these 99 recommendations, and it's finding a helpful way of challenging the system and ourselves. Really, is very important.
Jane.
So I think that we have, as others have referred to, we have got a really good opportunity as we have more integration and alignment with NHS Improvement to look at how we do this once across the system. We currently both have different quality groups where we sometimes review the same issues. NHS England has slightly different responsibilities in NHS Improvement, but I also think that we've done a huge amount of work around quality across all the domains since the Mid Staffordshire inquiry and the Robert Francis report. But one of the things that we have as systems, I think, concentrated on is much more about assurance. And although that is clearly very important, there is something about being more predictive and about actually being able to work across organisations and systems to look and identify things potentially before they happen, which we have done with some of the work we've designed and implemented initially in the north and then across the country. But one of the things I think we haven't had a consistent and a coordinated approach, which we have got an opportunity to do more on, is around, so how do we improve? So it's not just about assuring, it's about how can we use the information, how can we use the improvement methodology, or the teams and the clinicians and the staff that we've got, and patients and public, to actually improve the services. And I think there's a really significant need, I think, to shift from purely assurance to improvement. And I think we have got an opportunity to do that as we move forward, and I think it's an opportunity we should really grasp.
So I would support that, Malcolm. So I think in essence what we do and should be doing is monitoring quality, and we do that through a variety of mechanisms. So the national clinical audits are a very good example of how we monitor quality. We should then triangulate all the various information points we've got around quality and pick out themes in areas where we need to focus, for example, and then drive that into work on improvement, which is what Jane has just been talking about. And we clearly need to do that within NHS England. The opportunity of working more closely with NHS Improvement is to do that as one. And of course, the improvement part of NHS Improvement is a very key term in that name. And across other bodies. So we shouldn't forget that the work the CQC has done over the last 4 or 5 years has really contributed to our understanding of quality. And I should mention on that, with that respect, that the National Quality Board is a forum where all the arm's length bodies or national organisations come together to discuss quality, and that's co-chaired by myself as National Medical Director of NHS England and by the Chief Inspector of Hospitals, Ted Baker, and we've agreed that we will relook and we will refresh in the light of the various changes that have occurred over the last few years how the National Quality Board works. But in essence, it's driving that continuous improvement cycle. Monitoring, triangulating, improving, and then going around the cycle again. And I would absolutely agree with Jane that one of the things that we collectively need to do is to ensure that we are focusing as much on improvement and continuous improvement as we are on assurance of quality.
I think that's absolutely right. I mean, the other aspect of it is learning from incidents.
Yes.
And through the complaints procedure, the Parliamentary and Health Ombudsman procedure.
Yes, absolutely.
And I think the impression you get from the paper often is that this isn't joined up. Incidents are recorded and action is taken, but not so much the learning, which then drives through everything else. And also, the sheer complexity of this is quite extraordinary. I know this is a very complex ecosystem that we're talking about, but if I were somebody working in a clinic, aren't I just going to be submerged under a pile of recommendations and suggestions and guidance and toolkits, etc.? Is there a way in which, as we work with NHSI, that we can improve and simplify the support that we give to quality improvement through the system?
I think as well as between NHSI and NHSE, there's also the work of HSIB, the Healthcare Safety Investigation Branch, who are doing the investigations into serious incidents, concentrating a lot on maternity in the first instance. And I know that from their point of view, that there's something about if you have a particular, we have a particular incident in one part of the country, how do we take the lessons from that and make sure that somebody in another part of the country understands that very quickly? So we need to be able to work with HSIB, take the lessons and the learning from that, but also really, again, without bombarding staff with just lots of guidance and lots of toolkits and lots of information, how do we really spread that learning? And it's always been a difficult issue. It's always been something it's really difficult. The NHS is great at writing reports, writing recommendations, but actually delivering that into frontline changes can often be quite difficult. And it will that's a tough nut to crack, and it has been for many years, but one that we do need to look at together to sort, I think. Sorry, I interrupted you. What you were going to say?
I think you said it.
Sure.
I just wanted to echo what you said, Malcolm. I think the impression that one gets reading this paper is the complexity of the architecture and the number of organisations that are involved with the best of intentions in trying to improve quality, which overall, I think a sensible person would probably acknowledge that that complexity is probably counterproductive. And the more one tries to improve quality from multiple directions in multiple different ways through multiple organisations and multiple teams, the more difficult it is to actually improve. So I would think there were a simplification, removal of duplication and overlap is going to should happen, and in the meantime, all of the, as many as possible, ideally all of the bodies that are engaged in improvement ought to be working to a similar set of principles to make it easier for people to make real improvement on the ground, and underpinning those principles should be about, an understanding that in order to raise standards and get better, local teams and local leadership need to be empowered and supported.
I was just going to say, I was as a former member of said quality board before it was changed, the thing that struck me was that I agree with the notion that this stuff falls like snow and lasts about as long, and it's humanly impossible to engage with it all. But to give you that a lot of this stuff is about what specific professionals need to do in certain circumstances, which is quite technically complex and needs to be there. So it can't be generic because there's a difference. And then there's the other bit, which the extent to which that needs to be hidden, we need to see that, is debatable, and I don't think we do. But then there's the bit that I'm really conscious of, is that how do we learn, to your point, across the piece? And I don't just mean learn about what to do and what not to do, but how do we learn about leadership, and how do we learn what leadership actually supports improvement? And we've not had a lot on that. It's sort of, and it relate. I think, and my final point is that it relates to the previous conversation. Quality for whom? How? This conversation is missing if we can't say, well, what's the experience of it, and what's the experience of it for whom? So I think there's something about principle. There is something about principles. But there's something about how we build genuine learning culture around this stuff, which I think is absent.
Important questions, and I could give you examples around the health system of where there are activities going on which are absolutely addressing the points you've raised. I think the challenge is how we collectively do that and we spread that.
It's how we know, it's line of sight of learning.
That's the challenge.
I think the critical thing is that we have responsibility for a system. This is not, as in some countries, each institution worrying about quality in the institution. We have the huge opportunity of oversight of an entire system. Yet we, as NHS England, with NHS Improvement, don't actually control the whole of that system. We have responsibilities vested in other arm's length bodies, principally CQC. We have the coroner's system. We have the parliamentary and health ombudsman system. And what's critical for us is to be able to distill what comes from there as part of the learning, to ensure that the relationship with CQC continues to inform what we're able to do in terms of delivery with NHS Improvement. But I think picking up Joanne's point in particular, the ecosystem that appears in this report appears to have grown and grown and grown, often as a consequence of different incidents occurring at different time, and perhaps has reached the point where some distillation would be beneficial all round. So if we can commend that to you, Steve, and let's mark it up as one of the areas where we know that we can get better value by working in a much more integrated way with NHS Improvement, plus the others, but as an early win potentially for us in that system would be valuable. Any other issues on this paper? No? Thank you very much. We're going to move on now then to item 11, which is the NHS performance and progress on next steps. Matthew.
Thank you very much. So this paper runs through the main 5-year 4-review delivery areas, and it presents data up to February for A&E performance and January for the other performance indicators. I should start off by talking about urgent and emergency care, as this seems to be the longest winter that I can remember. So we've seen the highest flu cases in 6 years, and that peaked at something like an additional 2,000 beds across the NHS with flu patients in them compared to last year. And we've also had a spike in norovirus. That created across the NHS an enormous amount of pressure, and I think, as Simon said right at the beginning, grateful thanks to staff across acute community, primary care, social care and 111 for the work that they've done over this extended period now to keep the NHS safe and on track. So despite that, we continue to see this year almost 9 in 10 patients seen and treated within 4 hours. The year-to-date figure is just under 89%. And 360,000 more patients will have been seen and treated within 4 hours than last year. And I think the work that's been done across the country on the urgent emergency care plan has made a very significant difference to that. We've seen 111 take 15% more calls in February this year than in February last year. And the number of those calls now receiving a clinical input is up to almost half, or at 46.4% compared to just below 30% a year ago. We've got 98.5% of our hospitals now have front door streaming, so that the patients who have the most serious cases get streamed to the into the A&E department, and the patients who can be seen by primary care in A&E get streamed to those. We've seen a lot of work done across primary care and other service designs to try and keep people away from A&E if they don't need to be there, and to be treated in other more appropriate settings. So the A&E attendance increase in the past year, on the year to February, was 1.2% compared to a 4% growth rate year on year for the previous four years. And type 1, the main A&E department A&E attendance has grown by less than 1% to February. Whereas the urgent treatment centres, the services that we've created for less serious urgent cases, have grown by nearly 5% during the year. So we can see that balance in the design playing out. And the work that's done between health and social care around delayed transfers of care have seen us release about 1,700 beds since February 2017. So we now have the lowest level of DTOC beds since August 2015, 23% fewer than the same point last year. The combined effect of releasing those nearly 2,000 beds gave us the space to deal with nearly 2,000 additional demand for flu, which meant that the NHS has felt just as busy this year as it did last year. We had hoped that work on DTOC would relieve the pressure on and allow performance to improve. What's actually happened is performance is at a very similar level to where it was last year, and people are working just as hard and under just as much pressure and holding the system together. So we've got a lot to think about as we run into next year on what is the plan in order to make next year better than this year, and that's going through our planning round at the moment, trying to ensure that we've brought the right volumes of activity to ensure that we can open the right amount of capacity to manage next year's demand are the discussions that are going on across the NHS at the moment. Turning to primary care, we're delighted that we now have we've reached an agreement with the GPC around the GP contract for the coming year. We can also now see that 55% of the country is now covered by extended access GP services, which is a tremendous achievement. It's ahead of where we had expected to be at this point. And recent research has shown that in the areas where there is extended access, on average, there's something like a 10% reduction in the number of minor attendances turning up at A&E. So it is impacting on the ability of patients, improving the ability of patients to get primary care services as and when they need them. In cancer, we're treating more patients with cancer, 5.4% increase on the number of patients treated in the 12 months to January compared to the previous 12 months. And 93.8% of people get to see a specialist within 2 weeks of referral, by their GP, so that's exceeding that target. We are still struggling and still working on the 62-day cancer target, which is currently at just over 81%, and we have just invested another £17 million in trying to improve performance against that standard. Mental health, we are on track still to hit all of the targets that we set around early intervention in psychosis, in eating disorders, in IAP services by 2021. We have seen increased investment across the NHS in mental health services. And lastly, just to touch on elective waiting times, performance in January was just over 88% against the 92% target. So that's obviously disappointing that we're not hitting the target, and is down a bit on where we were a month previously. But nothing like the reduction that some people were concerned that we would see because of the cancellations that hospital had to put in place in order to manage winter demand. So part of our focus for the planning for the coming year is to make sure that we have enough elective capacity to in the coming year stop the waiting time position getting worse, stop the waiting list from getting any longer, which will require CCGs across the country to be buying significantly more activity than they bought in the previous year, and those conversations are going on at the moment. So we would expect in the coming year to do more elective operations than we have in the past year.
Thanks,
Thank you.
Just one question, when you refer to the reduction in detox occupation, how sustainable is that? Are we able to hold those numbers down and continue to reduce them? Or is there a risk that those beds start to be occupied again?
So I think the answer to that question, to both those questions, is yes. As in, yes, it is sustainable, but it's going to require the continued efforts that we've seen in the past year. And yes, there is a risk that it will turn around if we take our eye off it. And it's taken an enormous amount of joint working between the NHS and social services in order to achieve that. And our ambition is to go further and to release another 900 detox beds in the coming year. So we need to continue to do that. And given that it's not being funded by huge increases in additional funding, it needs to be done by working smarter, working better, making sure the right patients are getting the care they need in the right places.
Thanks. Questions, comments to Matthew on this report? No? Okay, well, thank you,
Thank
Matthew.
you very much.
We've got the full written report, so grateful to you for highlighting the principal aspects of it. So we're going to move on now to the next item, which is the month 11 financial report. Paul.
Thank you, Malcolm. The document in front of you summarises our forecast for the commissioning sector of the NHS as a particularly challenging year for the NHS as a whole draws to a close. I wasn't going to dwell on the numbers themselves, partly because the forecast broadly confirms the expectations I've set out in my report, certainly in the last 2 or 3 meetings, the profile of risks and mitigations that I've presented throughout the year, and partly, if I'm honest, because the scope to deploy any valuable insights you might come up with today in the form of further intervention in a year which runs out in a very short period is obviously increasingly limited. But I would just draw out a few points for you within the report. You might want to have Appendix A in front of you as I do so. And I guess what I'm trying to do is to relate some of the learnings we've got from 17-18 to some of the challenges that we've got as we look forward to 18-19 as I do that. I said in February that the CCG position was likely to finish around 700 million adverse to plan as the risks which I set out at month 9 crystallised in the forecast over the succeeding months. Our latest forecast is 687 million overspend, excluding the impact of lower quality premium payments, as you will see in the table in front of you. That sounds like a big number, but I think I need to point out the taxonomy of it to understand that better. So just over half of that variance is attributable to the price concessions agreed by the department on so-called Category M drugs in response to significant market issues during the year. This was not foreseeable either by CCGs or by us, frankly, at the beginning of the year. And while some CCGs have been able to absorb these additional costs through savings elsewhere, for many it's inevitably led to an overspend. As I reported last time, the issue has reduced substantially from its peak in the autumn, but costs are still running at least 10 million higher per month than usual levels, and that will need to be addressed rapidly if the planning assumptions the department agreed with us in our preparations for 1819 are to be met. The other half of the variance reflects the fact that despite record efficiency gains, which again I've pointed out in my report, many CCGs have struggled to constrain activity and operating costs to the ambitious levels set out in their plans. A level of ambition which, as I've commented before, derives in large measure from the need to create the system reserve for which commissioners as a whole were not explicitly funded. So just thinking forward, you'll recall from our conversation last time on planning that we've explicitly dealt with the underlying deficit, the second part of that two-part issue, through the Commissioner Sustainability Fund, which we've introduced for 1819. But also you'll remember that we're determined to ensure, by providing funding growth and then rigorously pressure testing the resulting CCG plans, that activity planning for next year fully accounts for likely growth, particularly in emergency activity, so that we're not faced with similar overspends as 1819 unfolds. Matthew referred to that in his operational update. I'd say we've made a start on that, but there is still quite a bit of work to be done to get those plans in line by the time that we get the final plans at the end of April. Turning briefly to direct commissioning, I'm pleased to report that specialised commissioning will again deliver an underspend, but within this, the South and London regional teams are seeing significant pressures from activity growth, and the positive financial position we're able to report is driven entirely by specific central budget underspends. Some of them recurrent, particularly in the form of increasing savings in drug costs from our commercial procurement work, which is really starting to show some significant benefits and greater value for taxpayers, greater ability to bring in new drugs for patients. But most of those benefits reflecting short-term timing factors in what's otherwise a very challenging pipeline of new drugs and treatments, which will undoubtedly dominate the position in 1819. As we've seen in previous years, we've got modest underspends in other direct commissioning areas, but I would want to reassure the board that GP spend in particular is not a significant factor in these variances, in line with our commitment to strong growth in our resourcing of that key area. In the light of the challenges both in the CCG sector and more broadly in the NHS, we've prudently harvested any additional income and underspends which have arisen within our central budgets during the course of the year, and we have deferred some discretionary expenditure wherever that was possible to ensure that we can fulfil our commitment to achieve financial balance across the commissioning system and deliver the system reserve of 560 million agreed at the beginning of the year. Whilst we've tried to protect transformation budgets within that as far as possible, we have had to defer some activities into 1819, so this is not without strategic cost, and we will need to do some catch-up in 1819 if progress with our key forward view priorities is not to be compromised. As usual, the system reserve is not included in the numbers reported in my schedules here, but that will come through as an improvement in the bottom line at the end of the year, in addition to a net underspend which we currently forecast to be 174 million. At the risk of perhaps overextending the usual metaphor, landing a 109 billion squadron of aircraft safely and simultaneously on a 0.2% postage stamp in a year which has seen significant turbulence, and there the metaphor stops, is not without its challenges. And there is bound to be some variation around the numbers I've presented here when it comes to final accounts. But I am now confident, as Simon said earlier, that we can fulfil all of our duties. And I hope, if anything, that the numbers we have put before you today will prove to be a slightly prudent estimate of our contribution to balancing budgets when it comes to the end of the year and we look across the health sector at the overall financial position. And then finally, as our focus turns more single-mindedly to 1819, even the accountants start thinking about 1819 as we cross the borderline into April, we will be working in ever closer partnership with colleagues at NHS Improvement to support each other in delivering our respective remits to achieve balance in the commissioner sector on our part, to achieve financial balance in the provider sector on the part of NHS improvement, and all importantly to work together to improve that combined goal and deliver the sector achievement overall. We've had to make some tough calls on the deployment of resources to increase the chances of delivering on those commitments and to make sure that local systems working in similarly close partnership have all the available funding at their disposal to deliver operationally as well as financially. But as the Met Office warned of one of the coldest Easters on record, my personal prediction, perhaps not one which will be characterised by a prize for insight, is that the significant challenges experienced by both commissioners and providers in 17-18 are unlikely to disappear on Sunday when we move into the new financial year, and operating without the safety valve of a system reserve, which is a choice that we made to maximise the resources available at the front line. So we won't have the 560 million or any equivalent of that as we go into 18-19. Operating in that way is going to be an acid test of the financial discipline and many other operational disciplines which are implicit in the financial performance that I've described for you today. So on that cheery note, I commend my report to the board.
Well, thank you very much, Paul. I mean, I think the lack of a system reserve in the coming year is going to be critical to our relationship with NHSI. I mean, it just has to work with a single view of the numbers across the two organisations and a single control management regime. Without that, I think we're in serious trouble. So let me open up the question. David.
So, Paul, thank you. I guess it's really about setup for next year. Obviously, the absence of a system reserve, because that cash has effectively been moved to support a higher provider sustainability fund,
exactly,
which is now 2.5 billion, plus or minus a bit. And clearly, we've established the Commissioner Sustainability Fund. And notwithstanding the talent that exists in your team to continue to manage the central fund, the central costs, which we've relied on for a number of years, it seems to me that we are changing the nature of our challenge from being able to manage and to hold, having got some things in reserve, which gives us a bit of confidence, to actually we have to hit our numbers in every single organisation around England, providers and commissioners, because there is no fund in the background. Which leads me, I think, to a recognition, A, that that's a more risky position that we're in. Secondly, that it requires, I think, behaviourally everyone to understand that there is no reserve. And thirdly, that the focus on efficiency becomes ever greater. And efficiency being the two sides of the quality coin, because in my mind they tend to go together. But how well do you think we're set, given that we have historically had very high level of ambition and not achieved it? I happen to think that's the right way of doing it, because I think it drives better thinking. But if the plans are predicated on very high levels of efficiency gain, both system-wide and institutional-wide, how well set up are we to deliver the efficiency ask in 18-19? We being the system as well as NHS.
Yes. Well, I maybe ought to take that in two parts, really, because I think the system is set up better than it ever has been before, but it's still very much coping with the challenge of working as a system. And it seems to me the big learning that we've had is the places that have delivered their efficiencies to the maximum extent are the places where commissioners and providers have done that together.
Which is an interesting insight.
Where they've got a grip on capacity in particular, yes, and therefore planned their capacity jointly, and where they can understand that an efficiency delivered over here has ramifications over there which need to be worked through and not therefore undermined by impacts that have not been predicted. And it would be foolish of me, I think, David, to suggest that every single part of the country has got that sorted. The numbers patently demonstrate the contrary. As I've gone around talking in particular to audit chairs around the country, I've taken to presenting kind of maps which bring the system performance to their attention, just to I think demonstrate where parts of the system have got their act together, both on the commissioner and the provider side, and other parts where either we've got weaknesses in one or other or both. but we will not have success in 1819 without every system operating like a joined-up system that is determined to win for the system as opposed to slog it out as best they can for their organisations. That's very much at the heart of what we're trying to support now with the joint work with NHSI, but clearly the two regulators or oversight bodies and or improvement bodies, whichever remit you want to focus on, is a supporting factor in that rather than the driving factor in that. So we can see some encouraging signs around the country. We can see where it's working, but we're going to have to support that. We have geared ourselves up to be more helpful than we have been in the past on efficiency. So you'll be aware, I think, of menus of opportunities that we make available, sharing of best practice, etc. We've got a dedicated team, which I very much hope will rapidly become a dedicated team across both national organisations, supporting financial resilience and how we do that in a more structured way. So lots and lots of things which make it more possible, but I wouldn't underestimate the challenge, which is why we're investing a lot of time into the planning parameters and making sure that, as I mentioned before, the activity plans of every single CCG around the country are consistent with a realistic view as to what will be required to deliver.
I think, therefore, Paul, I think absolutely right and useful insight. As we think about the board report going forward on finance, we have to also demonstrate that we're looking not only at the position on the NHS England account, if you like, but also on the system account.
Yep.
Because I think you can't look at one without the other. Clearly that's helped by the papers that we discussed earlier and the arrangements we based earlier, but that's going to take some time. And I don't think we'll have lost the year if we're not focused on that. So I think when you come back about the plans, but I think it was one of the most early things I'd encourage you and Elizabeth and the teams to do is to really think through how can we get quickly to system-wide insight as well as institutional insight, because I think that will tell us where should we be looking to help and support and work with teams that locally are having difficulty.
Okay, agree.
Good, agreed. Okay, I don't think there's anything else to raise with you, Paul. Thank you, and to your colleagues on the flight deck for your landing expertise. So we're going to turn now to slavery and human trafficking statement. This is the formal statutory statement that we're obliged to make, and the board simply needs to be assured that we have done what we should have done. So, Jane?
I think you've said it, Malcolm. It's in line with the Modern Slavery Act for 2015. We meet the criteria. The statement is there. It needs approval by the board prior to publishing on our website.
Okay. Are the board content to approve the statement? Thank you very much. We're going to turn now to emergency preparedness, resilience and response. To you, Matthew, please.
Thank you very much. This is the annual update to the board. It is part of our statutory responsibilities and a requirement under our mandate that we oversee the EPRR both for ourselves and across the NHS. So you have the paper in front of you. I would just say that this is an area where continuous improvement and continuous learning is very well embedded. So there is both an assurance process which is well valued across the NHS as we go out doing it. We have done an internal review which will lead to us putting more resources into our internal team, reflecting the amount of demand that we have seen grow. And we've had a Deloitte internal audit study which gave substantial assurance on it. So I would hope that the board would accept this paper formally and I think extend our gratitude to the staff who are working on EPR across the country on the series of incidents that we have managed very professionally over the past year.
Questions and comments, please, to Matthew. Joanne.
Matthew, I think some of us had the opportunity to spend some time with the EPR team and been very impressed by it. I just wondered if you'd had an opportunity to look at the Kerslake report after the Manchester Arena bombing, because I understand there may be some recommendations for health in there. Don't know if you've had an opportunity to...
Yes, thank you. I mean, there are small, I think there are 8 recommendations that are either identified as health or have a significant health element to them. They're all in, I think, in the space of learning that comes out of the event rather than major problems that had been discovered, and we'll work through them. But they are things like being clear on the applicants to health staff to not disrupt forensic evidence when they're assisting people who have need, to reflecting what was excellent work with the military on that occasion, making sure we build that properly into our processes and protocols, and to I think to formalise what our approach is to mental health support to victims and families and to responders. And I think Jane will say that from what happened in Manchester, we've brought some learning from that already down into London.
Yes, we did. So there were some significant lessons up in Manchester. One of them was around having forensic mortuary facilities and what happened. But the other work was around bereavement nurses. Bereavement nurses, and then the ongoing mental health support that was provided in Manchester provided some really good lessons, and we actually brought those down, and we had actually people from Manchester that came down to help in London, following both London Bridge and Grenfell in particular. And so at my CNO summit a couple of weeks ago, we had presentations from the Manchester team, and some of that was about some of that learning and how what they'd done differently there that we've then been able to replicate in London, which was, I think, very, very positive.
So it sounds like, just to pull that together,